in the interest of time, I'm going to move straight on to our next speaker, who has organised this whole conference. And what a fabulous job you've done, Inda. We're very grateful to you. I don't think you need any further introduction, so over to you.
Well, thank you, Mike, for having me today. And I don't think I can thank everybody enough in this room and those who are in the virtual platform for their support and for dedication and the energy what you have shown today. All the sponsors, external speakers, Ali, everybody else here. So we have heard about the service aspect today, and we also heard about the number game, what's visible in the database. But that doesn't mean that everybody is not delivering a service. And I think I'd like to put respect for those teams and services who are actually delivering the services, starting people on bisphosphonates and other treatment, whether it's a false care plan and whatever. But for some reason, it's not recorded on the FLSDB. But what are facts? We have to base our today on the FLSDB results. But my respect is with those teams whose teams are not on the FLSDB. Now, we heard about the regional variabilities and the type of services we have in Wales. So me, in my role as a national clinical lead for Wales, I am your voice. And this is how I like to start and close this loop. Because what you have told us today, if you have put on a hashtag, all those views are not going to be lost. We are going to go back and look into those views and all those questions and comments you have made for us. We need to look at that and see how we can take your voice back to our network. And then following on I would say, the person who is coming after me and who actually helped me so much, how we get it to the government. He's a partner in crime. So I think that's what we are looking for. And then my role is also to work with everybody else, how we can overcome those barriers, how we set up our priorities, what we need to do, what are those framework we have to have so that this process is not stopped here today, so that when you come back maybe a year later or 5 years later, you can see that progress and we can see that in a way that is evidence-based and is documented here. Now, this is the slide which I refer, and it does come with respect for those teams. But if we look at this number, the variability is very visible. But if we look at the 80-50-80 approach, that based on the FLS standards, we have to identify 80% patients. And we can see where we are within the health boards. And if we look at all Wales, the figure is about 9%. But when you look at the 50% aspect, which is that we recommended the treatment, we are green. So which means we should congratulate ourselves that once we identify, we're not that bad. But then we go to the next 80%, is that are we delivering that treatment evidence-based following the next 12 months? Because that is the time when people will stop taking these medications, either because of side effects or lack of knowledge, awareness. And we need to be thinking about that, how to improve that. And that's where our primary care colleagues, the nursing colleagues, what we have seen, and education steps in. But as we go down the line, if we have to see total number of patients, if I put a simply 20,000 patients in Wales having a fracture, we're actually giving evidence-based treatment as per recommendation to 200, so which is 1% of the population. So we need to do something differently. Though we are actually identifying approximately 10%, but not treating as far. And as a result of that, the work which we see in our hospitals, whether it's the fractures with the hip, it will not stop. It will continue. The medication doesn't work under 12 months. Now, if we had a group, we have all this, so what? And that so what is that the key part for us is that we should be signed up and dedicated to improve and support the delivery of care, what people with fractures need and what they deserve. And following on that, we take that responsibility and ownership of those things. But much more importantly about that is how we continue to develop this and take it to the next level, and how we reflect the key findings what Dr. Johansson has shown in his slides about the audits. That's a live audit. Anyone in the public can just go back and see how we are doing. But if we do not participate, we are not going to win. We're not going to impress anybody that how we are doing. So that's the key part of us, how we advise our actions. If we have done something, and how we take it to the next level, whether it's at regional, local, national level, but we have to come together as a team that we should continue doing that. And finally, that we have to have a mechanism to identify that good practice. and disseminate that practice to the other health boards. So I like stealing things from others. I don't want to reinvent anything. I'm really good in stealing. But if anybody has that, I do that. And then finally, put all these things together. So basically what I've described when I met few of you is your voice, and you have paid me indirectly or directly, and I'm your voice. I'll be taking all those things back with my colleagues within the Welsh government, putting it back to the health minister, and health minister will endorse it. And my partner in crime has got a special way to do that. So I'd like to conclude today that our collecting aim should be that let first fracture be the last. That's all from me. Thank you for having me today.